The room here is full of people, I'm sure. There are 100 times more people out there who would like to say and be engaged in this issue, because as we know, the issue of eating disorders and failing services are a massive crisis. And whenever I talk about it here in Parliament, I call it a national emergency. I'm Wera Hobhouse. I'm the Liberal Democrat MP for Bath and the chair of the Eating Disorder All-Party Parliamentary Group. And I've been the chair for now 6 years. And we've been campaigning on this issue with all the wonderful campaigners and the courageous campaigners of you here and wherever you are. And I said this morning on Women's Hour, where would we be here in Parliament without you? Telling your stories and telling your heartbreaking stories. We acknowledge that without you, the campaigners who are telling us about your lived experiences, but also carers, and I'm one of them. I wasn't a carer, but my daughter had an eating disorder, and I know what all of you, the carers and the clinicians, the researchers, and particularly those who have been suffering from an eating disorder or recovering, have been going through, and we are together. I am absolutely with you, and I really want to make a difference. I feel almost ashamed to say that we've been trying to campaign on this issue for such a long time, and we haven't really made the progress that I would like to see. But maybe now is the moment. This is the year when we are going to have a breakthrough moment, when we are going to end eating disorders. Far too many lives are being lost and families torn apart because we are failing to grasp the severity of the crisis. Our report puts forward a number of urgent recommendations, namely a national strategy for eating disorders, a confidential inquiry into eating disorder death, and increased funding for services and research. There is no time to waste in implementing these vital measures. I'm glad to be surrounded by an inspiring group of people here this evening who are committed to change as I am. It has been a pleasure to work particularly, and I have to say that again and again, with Hope Virgo, who is an absolute hero. Without Hope, we wouldn't have this report this evening. She has worked incredibly hard. We, as the Eating Disorder APPG, have gone through a number of inquiry sessions, again, put forward very expertly by Hope, who is now the Secretariat for the Eating Disorder APPG. But tonight, I want to thank you all who have bravely shared your stories or the stories of your loved ones with the APPG. It is great to see you are here today. I hope that our report shines a light on your stories so we can make sure no one faces the same experiences again. Thank you also to the many academics, experts, and clinicians who contributed to our research. Your input has been crucial to the report, and I hope to see the recommendations we have set out together put into action. Thank you all very much again for coming. I look forward to speaking with many of you here tonight and continuing this important campaign.
You'd think as a university lecturer, I'd be very used to just speaking out, but I'm here today as a mum and therefore hence a little bit out of my comfort zone. Our experiences, my experience and my daughter's experience is not that dissimilar to that of many people suffering or have suffered from eating disorders around the UK. You will notice in the APPG report, our experiences are not unique to us by any means. As a family, we've lived with anorexia for over 13 years. I don't think there are enough words in the dictionary to describe or indeed time to tell how tough and how challenging this has been and continues to be. But however challenging it's been for us, this just pales into insignificance to the horrendous years this illness has taken away from my daughter and the lifeless life she has led and continues, unfortunately, to endure at the moment. Anorexia invaded my family and not only took away my daughter, her education, her life hopes and aspirations, but also took away her happiness. I'd like to say at this point that the next few minutes will highlight just a few of our experiences. And it needs to be said that anorexia is a very, very individual illness. By no means is everyone's pathway the same as ours. It's not as complex or as complicated or as long. There's some amazing, happy and positive outcomes due to some very caring, supporting and knowledgeable eating disorder services out there in the UK. So here we go. I'm working on the basis that not everybody in this room can begin to understand how anorexia can create such a fear of food. So I'm going to ask you now just to take a moment. Please close your eyes and think for just a few seconds what your biggest fear is. And think how that fear makes your stomach churn. A fear that almost takes away your breath. So please just close those eyes and think of that horrendous fear. Now remember and think how that fear at this moment in time is making you think. So what on earth am I going on about? That fear that you've just identified and thought about doesn't dominate your life. You don't think about it 24/7. You're able to control that fear, able hopefully not to put yourself in a position to have to experience it day in, day out. Be able to choose an alternative to avoid facing that fear. So now we think about a patient with anorexia. That fear, that totally undefined, completely illogical fear for someone with anorexia is feeling at that moment. They feel it every single time they face food. They gain weight, their body changes, they feel alien in their own skin. These thoughts and fears grow stronger as the illness takes hold. The anxiety prior to each meal grows and grows, and the guilt and the sadness after eating anything just increases. So why is this? It's a well-researched and documented fact that a person suffering from anorexia has a malnourished brain. Being an organ, the brain needs to be nourished to function. And quite simply put, the brain is unable to process correctly when it's malnourished. It can take years and years of extensive support, therapy, patience, strong will and determination for a person with an eating disorder to learn how to control it and live with it. As I think back to the numerous eating disorder services we have encountered over the years, from adolescent to adult, community to inpatient, from one county to another, from acute mental health units to general hospitals, it's been a challenging and at times rather traumatic. Knowledge and understanding of eating disorders in specific areas has been very, very intermittent. Accident in an emergency or the emergency department, general mental health units, general hospitals, general practitioners, crisis mental health call lines. Compassion, education, training is needed in all these key areas that a patient with an eating disorder is very likely to encounter. No doubt in my mind, anorexia is a horrible, horrible illness. It has at times turned my daughter into someone I just don't recognise in terms of her thoughts, her very outspoken comments, her anger, her frustrations and her actions. But I know these are all very much traits of a malnourished brain. There have been days, sometimes even a few weeks, when she's felt she just can't fight this illness anymore. She is exhausted. She's continually told she's complex and complicated. These words add to her thoughts of being untreatable and rejection. In the main, she wants to move on, wants to travel, wants to party again, and wants to rekindle friendship. It's therefore incredibly hard for her and us to have over the years comments such as unmotivated, lacks commitment, non-engaged, nothing we can do to support her further, to being discharged on a therapeutic break with no continual forward care plan. So when I think back over the years, sadly, the negative experiences come to mind first. The time when 8 people entered our house to section my daughter. We don't even have 8 seats in our lounge, so we ended up sitting on the floor. The process took 3 hours. She was sectioned into an acute mental health unit, a unit mostly for men, a unit with little knowledge of eating disorders, completely unable to cope and support with eating disorders. The staff on the unit from day one said she shouldn't be there. She was terrified. Imagine male patients' comments and actions towards a young blonde-haired girl. She did not leave her room at all. She ate nothing other than the grapes that we brought in. 7 whole weeks later, so weak and at the stage when she had to be carried into the visitors' lounge to meet us, finally the eating disorder services come in to assess her, and she was in fact moved into an eating disorder unit the next day. I think back more recently when we had an 8-week experience of a general hospital gastro ward, to the twice daily trauma of being NG fed. My daughter being restrained by 3 hospital security guards in full body armour, with no training on restraining a frail person. The bruising, the handprints left on her neck and arms, the dislocated jaw. The trauma of this happened twice a day, every day. I remember one day arriving on the ward when this was happening to hear the screams coming from her room that echoed around the ward. The sound of her screams that will now live with me forever. It's well documented that there are just not enough study beds around the country. Over and over again, we hear of patients who are in units miles away from home. The alternative being patients are placed in general hospitals, in beds in gastro or general wards, which for both the patient and the nursing staff is really not appropriate. It's not uncommon in general hospitals for staff to have minimal, if any, knowledge of eating disorders, how to support, how to treat, what to say, what not to say. It's not their fault. Resources and training have simply not been there for them. I think back to the numerous visits to A&E over the years, and almost without exception, no staff were aware of MEAD, Medical Emergencies for Eating Disorder document. Nurses had no idea how to support, what to say, what not to say. Often obvious triggering statements, go and get yourself some hot chocolate, go and eat a biscuit, were made more and more times. And the A&E consultant simply would say after a 4-hour observation period, I've no idea what to do with you. MEAD is acknowledged as the eating disorder main go-to document and was developed as guidance to avoid medical emergencies. The use of signals, tests, alerts and stages highlight medical action needed. Whilst well acknowledged and used within the world of eating disorders, but not sadly within the wider NHS. You'll find MEAD further referenced in the APPG report. In several of the inpatient units we've encountered, there's been no psychologist in post. We've had to pay for one-to-one therapeutic support. In fact, we're currently paying now. Not every inpatient unit has a dietitian in post. There have been several times when there's been no clinician in post. Bank staff are regularly used with no ED training at all. All of which is quite worrying and sad to hear when comments are made from colleagues within the system that the severity of the UK eating disorder situation is being exaggerated and not that bad. So I ask the question here today, what other illness do we know that would be considered acceptable for a person to be restrained, to not have access to specialist care for duration of an illness that is evidence to be treatable, to be sent miles away from home, to be assessed, then turned away from specialist care with reasons such as BMI not low enough, not motivated to full recovery, too complicated and complex, too stuck, can't have anything different, no specialist beds available, community teams full, waiting lists, and there are many, many other comments we could add to this. These are comments we are hearing from eating disorder sufferers increasingly. That's yesterday, that's today, and no doubt at the moment it will be tomorrow. And why we're hearing such comments for an illness that, despite the complexities, is evidence that eating disorders are fully treatable with a comprehensive approach that includes nutritional, medical, and therapeutic support. And finally, our daughter is currently considered stuck with her illness on an inpatient unit. She's been there for 17 months. On her bad days, she tells us she is too exhausted to carry on. She's been told she's complex and complicated, so she sometimes thinks she's beyond help. And then thankfully, on good days, get a glimpse of our real daughter. A slight smile, a giggle, and we know she's still there, she's still fighting. Then she tells us, I don't want to die, I want to travel, I want my life. So we live in hope that one day, with the right support, care and understanding, she will at least be able to live a life where she is content, happy, able to control her eating disorder. I'm immensely proud of her today, in fact, day in and day out, but even more so today. She was determined to get off the unit for a few hours, to be standing here beside Hope and the team, and she's here today. And I'll take that as a proud moment.
Foundation Trust up in the Northwest. I also used to run NHS benchmarking networks, so I've collected a lot of data on the incidence, prevalence and delivery of services around eating disorders over the years. So I just want to share some of that with you. Just following on from Nicky as well, I do have a family member who's been severely impacted by eating disorder as well. So like many, many people in this room, we all have a story and an experience about how difficult things are, you know, from trying to get pretty much non-existent service in primary care through to the absolute central value of specialist care, which in my case was from an adult community eating disorder service. And one of the difficulties is that when people are discharged from those services, there's no way back in. Unless you reach another hyperacute stage with your illness, it's very, very unlikely you'll be able to re-access care. So in terms of my story with NHS benchmarking, it's the world's largest healthcare comparison service, and I ran the service for over 20 years. And we collected data on everything that moves really in the NHS. And there are some real success stories within that around mental health care. So some great success stories which have been driven by policy and national strategy. We look at children and young people's mental health services. Since 2011, they've quadrupled in size, and that's the financial investment, it's the workforce, it's the number of people who've been able to access care. And obviously eating disorders is part of that success story. And then there's some other real biggies like first episode psychosis services, which doubled in size, and we now have a national 2-week waiting standard for people experiencing a first episode of psychosis. Perinatal mental health, another massive one for women experiencing postnatal depression and postpartum psychosis, and they've actually increased in size 5-fold over the last 10 years. Just think what that could do if we were to apply those principles to eating disorders. Possibly the jewel in the crown for NHS England, the improving access to psychological therapy services, where 1.2 million people were able to access that care each year. So there have been some real success stories. Now, I suppose the point I want to make here is that strategies work, strategies help, and when they're tied with a national resourcing commitment with workforce development, they actually change things. One obvious exclusion from that list has been eating disorders, and it hasn't featured, especially adult eating disorders, in any national strategies. Policy teams are aware of this, and so I think what it brings us to is the fact it's a choice that's been made historically. And what we clearly are all here tonight is to suggest there is a compelling case for change here about the need for a national strategy. I started to get concerned about this maybe about 10 years ago when we were working with all the national data that was coming through. There was a really helpful report from Beat. Beat do fantastic work in terms of advocacy. And there was a sort of rule of thumb that eating disorders potentially impacted about 1.25 million people across the UK. I think the thinking has moved on quite a lot now through some really hard work that's been done. The Royal College of Psychiatrists and people like Agnes have done some incredible work here. And I think the consensus has now settled that it's actually somewhere between 2 and 3 million people over the course of their lifetime could be affected by an eating disorder. But let's look at how many people actually receive care. Over the course of a year, and this is children and adults, the best figure we ever came up with was that 40,000 people were able to access care. And at the moment, there are about 23,000 people who are being supported by specialist eating disorder services. So whichever way you look at that, it's about 1 to 2% of the background population who are actually accessing services. And for me, this is the largest treatment gap in UK healthcare. So in terms of, if you're okay, I'll just say a few words about my new day job, which is as a non-exec director in Lancashire, South Cumbria. So we're a big mental health trust, we're the 5th largest in the NHS. We serve 1.8 million people. We're rated good by the CQC. We've got an excellent culture, values, and we always aim to do the right thing and provide the best possible care. We've got an absolutely fantastic all-age eating disorder service, and practitioners within that service, they normally book in 4 patients a day. They're motivated to provide the best possible care. And we have really quite short waiting times. However, if we don't have an inpatient unit, if the patients need inpatient care, they'll travel 50 miles to Cheshire and Wirral, or they'll travel 200 miles to Glasgow, to a Priory unit in Glasgow. And that's not an unusual journey to be made. We also, for this, the 5th largest mental health trust in the country, we don't have a consultant psychiatrist in eating disorders in our service. In fact, you know what? We've never had one. And what so our medical cover is really thin. We had a couple of sessions of GP time. That was probably the peak of the medical cover that we ever had within the service. And we're not unusual. Half of English mental health trusts don't have a consultant psychiatrist in eating disorders within the service. And what this says to me is that actually we have structural weaknesses in the way that care is being planned and delivered. And this also speaks to the lack of a national strategy. That isn't the case in many, many other mental health services, but it stands out in adult eating disorder services. And obviously, as a non-exec director, none of this sits easily. My job is to provide assurance that we're doing the right thing for patients, that we're doing the right thing for taxpayers. And I really welcome the statement in the APPG report that actually every trust needs a non-exec director who will be accountable for delivery of eating disorders care at trust board level. Okay, so in terms of the future, there are some proposals for investment at the back of the report. I think it's Appendix 6. And I think any investment will help actually, but some of the standout issues for me is about something in primary care. This is a long-term condition for many people, and therefore a quality and outcomes framework would be a great place to actually provide some more resilient care within primary care. Making NHS talking therapies accessible to people with an eating disorder, adults with an eating disorder, would be fantastic, and that would be another game changer. And therefore, there are those multiples of investment that we've seen in perinatal, that we've seen in CAMHS, that would be game changers around adult eating disorder care. Just humour me on this one, if you will, but I'm really grateful because I've been awarded the Churchill Fellowship, and the fellowship is around exploring strategies for adult eating disorders care. And I'm going to be working with the Australian government, and they do have a national strategy, the first big country in the world to do this. I'll just call out some of the elements of their strategy. It's a national action and a roadmap based on national standards. There's a statement in their strategy that eating disorders are everyone's business in all health and care systems. Their objectives are that eating disorder prevalence is reduced and that recovery outcomes and quality of life for people impacted are improved. And that's being driven by a programme of minimum national standards. And they have this vision of one day contributing to the process of finding a cure, because after all, this is a largely curable condition. I hope that's helpful.
Like Nicky, we'd like to preface that there are so many well-meaning clinicians in eating disorder services who try their best to deliver the best and most compassionate care that they can in a historically grossly underfunded system. And we also can't dispute the fact that there are far from optimal services, perhaps due to healthcare needs being balanced against resource allocation, perhaps for other reasons. When my eldest daughter was diagnosed nearly 10 years ago as a 17-year-old, the reality she faced was totally incomprehensible to us. The threat to discharge her from services for reasons of non-compliance was set out in a letter to her. Fast forward 10 years later to today, and our family is probably testament to the difference weight restoration and ongoing psychological support for however long it takes can make. We saw the difference that inpatient care scaled down to intensive day patient and then weekly interventions can make. Crucially, from the same team, treatment beyond the low BMIs at which patients are often discharged. With this provision, which we had no choice but to do through our own financial resources, our eldest daughter went from being told that she was not sick enough to access treatment to the first of her 5 inpatient stays within 8 weeks of her initial presentation. The same daughter who at one stage begged us to let her die during one of these admissions went on to study at the university she'd always dreamt of, re-engaged with life, was married a year ago, and in her wedding speech referenced those dark days and thanked us for not giving up on her when she had given up on herself, and as she saw it, services had given up on her. She's now in the first few years of an exciting career and lives life to the full. We were lucky, but how many clinicians actually get to see patients who are really, truly recovered? I'd like to say that over these 10 years, the situation has improved, but today the stories that as carer representatives we sadly hear from distraught families on a daily basis are beyond most people's comprehension. In a civilised society, we really should expect more. These stories are of patients who are not just in adult services, they're also in CAMHS. The reality we hear is in stark contrast to the data we are presented with that things are actually satisfactory, acceptable, or even improving. We hear of children who are being admitted to inpatient services who are becoming more entrenched in their illness and not less. Many services here in the UK are currently not set up to provide the continuous and integrated care pathway necessary to facilitate the strong foundation necessary for a robust and ongoing recovery that all patients deserve. We say that recovery is a marathon, not a sprint, and it is currently, but it really needn't be. Recovery is possible at any age, severity, or duration of illness. And I think we can all agree that to reach a severe level of illness or a very low BMI does not happen overnight. Remaining at an underweight BMI further entrenches behavioural struggles, and the iatrogenic harm that occurs by allowing elongated treatment or lack thereof is undeniable. It's seems to me that current services currently are setting patients up for ongoing chronic and entrenched illness, with their cognitive capacity hugely compromised by their illness, all too often without adequate medical oversight or support in the community. Right now, patients rarely, if ever, leave treatment fully recovered, and this report has highlighted that many are being discharged at a severity of illness that is nowhere near weight restoration, without which there is no recovery. Often isolated and unsupported, and crucially without medical expertise, carers are being tasked with keeping their loved ones alive at horrifying levels of illness, and this is never acceptable. The levels of stress and strain caused through helping someone to recover cannot and should never be borne solely by the family within the community, which too often we hear is happening. Worse still, patients are discharged and expected to manage their own health whilst fighting an illness that may tell them they're not ill. You may find it as hard as I do to understand why eating disorder patients are treated so differently to the rest of society. If these illnesses were treated intensively right from diagnosis and not given a wait-and-see approach, we would see the difference. Weekly psychiatric, therapeutic and dietetic support in the community, again, was what we had to provide for our younger daughter when she became ill. It still took several years for her to recover, but far fewer years. We should be providing this level of support for all eating disorder patients within the NHS. So to change nothing and to carry on discharging patients when they are still so severely ill with their cognition compromised is nothing short of cruel. Everybody has the right to health, and that includes all people with eating disorders, and it is our duty as a civilised society to ensure that this basic human right is upheld. We need to be far more ambitious in our approach and not just accept the status quo. We need true accountability, not to blame anybody, but to address and move on from an often dubious culture that can exist and a culture to which our families are subjected. Eating disorders are biologically based, yet we do not treat sufferers with anywhere near the same compassion or longevity as those with cancer or perhaps diabetes. I won't go into all the things that need to change. You can read the report's recommendations. However, it really isn't rocket science. These are treatable illnesses. Change would also benefit the day-to-day reality of clinicians, many of whom are trying to deliver the best possible care with what must feel like their hands tied behind their backs. And Ulrika, I just want to say I didn't take your words, but you said that independently earlier on today. Someone I work alongside always says that one day we should expect to see apologies to all eating disorder patients who were subjected to inadequate treatment and to the families of those who died when their lives could and should have been saved. They too should be here living life to the full, and the families should never be scrutinised in the manner to which they are subjected after they have lost their loved one. We need a culture of learning from tragic outcomes and not one of concealment. Heartfelt thanks as ever to the amazing Hope Virgo for her unfailing efforts to uncover why it is in 2025 an ever-increasing cohort of our society is being failed in such a manner. This is a unique opportunity here for policymakers, research funders and clinicians and us all to be remembered as the ones who listened and acted. Thank you.
I'm also Parliamentary Private Secretary to the Health Department, but I'm also a practicing clinician. I'm a surgeon. And I want to first of all pay tribute to the families and the patients that have been brave enough to share their stories and join us this evening. I know it's no small feat, so thank you for being here. And I think the fact that even as a surgeon, I've come across patients with eating disorders many times in my career speaks to the multifactorial, multisystemic, multidisciplinary problem that it always was, but thankfully now is being treated as. So I think that's a big step. I mean, I remember when I was a very junior surgeon, you would have no training in this at all, and even now it's very sparse, but at least it's on the curriculum for the surgeons coming through now, because unfortunately we see the extremities of these problems when the patients need peg tubes and lots of intrusive feeding interventions. And what I would like to say, as a member of Parliament, as a clinician, as someone that normally is represented in the Department of Health, is that in many ways things that have not progressed as quickly as they should have embody some of the shifts that we're trying to create in the health service. From sickness to prevention, and also from hospital to community, because it should never ever be the case that the trigger for specialist intervention should be a moment of crisis. That should never happen. And I think I feel very strongly that in our 10-year plan, in any wider mental health strategy or health strategy, that something like this should be an exemplar of how things should never be allowed to happen, and the status quo simply is not acceptable in that regard. I want to pay tribute to all the research that's taken place through the NIHR. It's an organisation that's close to my heart because I did my own research through the NIHR. I know the valuable work that they do and the funding that they provide. And also to say that we are taking this seriously. From 2017 to now, the amount of money that we're spending in community-based eating disorder help and services for children particularly has doubled. On top of that, I know UK Health and Research have a £4 million+ fund to try and pump prime some of the researches that are going on in the eating disorder research network. Please use me now and in the future as your conduit to the Department of Health, and happy to be at your service, and thank you for having me here this evening. Thank you.
Medical Director in CAMHS services in Merseyside NHS Trust, which is one of the largest providers of mental health care in Northwest, in and outside Liverpool. I'm also the chair of the Faculty of Eating Disorders, and I recognized lots of colleagues there when I started to work as the member of the Faculty of Eating Disorders around 10 years ago. And I've done and worked with lots of colleagues here. And it has been quite an emotional journey in the context of lots of patients and carers who I cared for when I was delivering the care for them, leading the Children's Eating Disorder Service, which is quite big and covers around 800,000 population in that big geographical patch. We heard quite a lot, so I'm not going to say what is not working, but important thing to understand as a clinician, I would like to say, is that eating disorder is a complex disorder which has massive level of physical health condition, which affects the whole body. And in simple terms, not all the services across the country have input from any medic. And you'll be surprised to know that many of the services do not have even nurses working in them. So they are just led by therapists. And they are trying to do their best. I'm not here to blame anyone. And I'm not going to feel defensive because NHS is my life and blood as well. It is not like I'm separate to NHS and Royal College is different from NHS. We are all together in the whole system, I must say. But we can improve the system by using the means which we have got. And I would want to applaud colleagues from NHS England here, Dasha and Adrian, our ex-president. I remember Adrian, so much courage and encouragement you gave us in the Faculty of Eating Disorders when you were the president of the college. And, to ask for money, to take it to the front line and make sure, working with colleagues from BEAT and making sure that all the money which is there on the table is accounted for to reach the front line. The unfortunate thing is that we have £49.5 million recurrent placed funding over the last 5 years, besides the money which came in 2015-16. And BEAT have done the audit, and only 40% of that money from the first lot reached the front line. That was the evidence in their audit. The new money which came, like £29.5 million in last 2 years, we do not have much evidence that actually it has reached the front line. And in Faculty of Eating Disorders, where we have representation from all across England, around 20 consultant psychiatrists who are part of the membership, BEAT is part of the membership, FIST is there too, and then we have patient and carer reps, and they all give us feedback from there. So what we have on the table, if we could use that effectively, if we could make sure that it reaches the front line, it will be a game changer for Children's Eating Disorder Service, I must say that. And respected members of the Parliament who are here, and I'm sure they will back it up and make sure that it will happen. And Adrian, you as a medical director of the NHS England for mental health and autism, of course, we know that in adult mental health world, there is a getting it right first time. The GovT system is put in place, whether we could adopt that for adult eating disorder services, children's eating disorder services, and make sure that the system works smoothly. There is some accountability of those money which is placed and is on the table. So while there is a need for new money for adult eating disorder services, there is a need to account for the money which is already placed. If you do not do that, we'll be here in 5 years' time and we'll be saying the same thing. Of course, we might agree that, well, I don't want a confidential inquiry on death, or we might agree, no, it is needed. Whether you do it or not, it will happen. Whether DHSO will sit down one day and do it, whether coroners in their different jurisdiction will do it, or a patient-initiated manslaughter charges will do it. It doesn't matter how you look at it, but it will happen. It is happening in many domains. Patients are bringing now manslaughter charges. The police is bringing the charges, and poor clinician on the front line is in the firing line. They believe that they do not have the resources, then they get into some defensive practices. They get into some practices which is, because of lack of resources, I would say. So we need to support the clinician on the front line if you want to get the best people out there, because it is very complex condition, which all the patients and carers here have been telling us, and we know that already. If you do not do that, you are going to lose those consultant psychiatrists. You are going to lose those family therapists, nurses, dietitians, and all that. And that would not be good for the patient care. So thank you.
Thank you.
I'm a geneticist at King's College London, and I work on the genetics of eating disorders in a project called the Eating Disorders Genetics Initiative, which APPG UK, which will be familiar to many of you. So first of all, thank you to everyone who gave evidence for the report, and to hope for the opportunity to speak about the critical need for enhanced funding and research in the field of eating disorders. Eating disorders are a topic of urgent importance, but all too often inconsistent attention from policymakers and funders. And I think it's important to bear in mind that eating disorders are not just social and environmental, they're also genetic, just like all disorders with severe mortality and morbidity. While the majority of the risk actually for almost all eating disorders is genetic, we are currently limited to biological and social approaches to prevent and treat these illnesses. The findings from genetic research tend to indicate that these eating disorders are both psychological, psychiatric, and metabolic illnesses. The UK is currently, I think, leading a lot of the research in the genetics of eating disorders, going right across from anorexia to binge eating to ARFID, for example. APPG UK, which I lead, is the UK's or Europe's largest research project in eating disorder genetics. We've already revealed how genetic and environmental factors interact in complex ways. But despite these advancements, what we actually see then, compared to other medical disciplines, is that we have inadequate funding. So we published the first really large genetic study for anorexia in 2019. We identified four single gene loci, and 4 single genes that could be functionally important and drug targets. But almost no funding has come through from policymakers or industry to actually develop them into as therapeutic targets. However, it's not to say there aren't positive movements. So NIHR funding has been mentioned, and NIHR has funded in the past the APPG UK project, and it has funded lots of clinical trials. Similarly, the MRC and the MRF have funded recently large amounts of funding, 4 projects across London, Birmingham, and Edinburgh. And these include projects that are including the Eating Disorders Clinical Research Initiative, which I lead with Karina Allen, and there's a poster about that over there. An ARFID focused research project at UCL, the Eating Disorders Autism Collaborative in Edinburgh, and a social anthropology eating disorders project in Birmingham. In particular, the MRF also has the Medical Research Foundation, the charity arm of the MRC, has had lots of foresight here and has funded fellowships for junior researchers to study eating disorders over a number of years, and that's having a positive impact in the field now, building the workforce, essentially. And today I ask you, policymakers, clinicians, and those with lived experience to work together with the research community to champion this cause. I mean, I know you do this already, but we have the knowledge now, I think, and the tools to make a difference. But without sufficient, consistent funding and collaboration, we risk not being able to offer improved therapies to the millions of people affected by eating disorders. So thank you for attending, and thank you to Hope and the APPG. Thank you.
I'm not actually going to talk about my experiences in depth, just some more general reflections, because I'm finding it pretty heavy going, and I think this is a great success to have this report, but it's a real sign of systemic failure, actually, that we're here at all. So I don't have much to add in that sense. There's nothing new in this report. There are some new asks, but we know these things already. I mean, from lived experience, we know these things already. We know that services are so starved of resources that the care offered to the vast majority of people is just a fraction of what they actually need. And if we get any treatment at all, we're made to do with, we have to deal with just the crumbs of what we need, and we might even be treated as though we're sort of greedy or asking for too much if we challenge that. And the reality is that a tiny minority get any care at all, even though many more actually do seek it. Help seeking, that I don't think is the problem. Everyone who is not the right kind of sick, in the right kind of way, at the right time, in the right place, in the right body, those people are met with a response that suggests or tells them that their problem, whilst it might be life-threatening, is invalid somehow, to be met with a meaningful response. And it's not just us invalids that are harmed by a system that has neglect built into it because it's so under-resourced. The staff are harmed too. We've heard about that a lot as well. And being required to neglect the needs and the rights of the patients that you've gone into your career to help is extremely distressing for many people. So this is the reality. Pretending otherwise, I think, would be to be complicit in this exclusion, in this normalization of neglect that many people have had to live with. And we have to remember that neglect is a form of abuse, although it's a kind of abuse that's very easy to say, look at what you've done to yourself. And I think that stigma is reinforced there. That's certainly my experience, which I'm not going to go into in a lot of detail, but having had severe anorexia and severe bulimia over 20 years, those conditions are horrible, involve a lot of pain and suffering. But I feel for me, the neglect has been worse, and being blamed for my pain and suffering has been worse than the actual condition itself. So the good news is that it doesn't have to be this way. And I don't say that out of blind hope. There are lots of solutions and evidence is at hand. We know about prevention, we know about early intervention, integrated treatment, appropriately intense treatment. My experience is that it helps when it's appropriately intense and integrated. We have lots of recommendations from the PHSO. So the good news is that we haven't implemented them yet. That is the good news, because had we have implemented them and we're still in this position, how awful would that be? But actually there's plenty of things that suggest there isn't a nihilistic picture. And we don't need more evidence to act now. We don't need to better document the decline of our services to find even better ways to articulate the problems or to count the costs, because we've counted the costs for years. People here have counted the costs for decades, and to the point that we can't even count the costs anymore, because there are some things that you just can't put a price on, and it's heartbreaking, isn't it? And we've raised the alarms. That report that was called Ignoring the Alarms, genius metaphor there, because it's kind of like there's a fire alarm and we're like, can you help us put out this thing? Probably British, we're like, excuse me, there's a problem here, can we have some help? And then the ignoring of that, and then so we might cry for help, and then that might be pathologized as a mental health problem. And whilst instead of sort of fixing the fire and we're saying, what are we going to do about eating disorders? The response that I've got in some of my work is, I'm told, well, we're very, very busy trying to fan away the smoke from the fire alarm so that we, marginalize those people away from knowing that they're suffering, and we're very busy doing that. Or, we're really busy putting out new fires that are starting, prevention or early intervention there, rather than actually addressing the fire that's been going on, ruining people's lives for a very long time. And even if we did put out that and adequately resource our services, what about the damage that's been done to people? What about restoring that somehow as well? So I think that this is a cultural problem as well as a resource problem. And I would describe this using that metaphor. We know eating disorder services are failing, continuing to, and that they are ignoring the alarms in this sort of systemic way. I think it's a culture of ignorance that has to change. And an answer that's we are busy, it's not good enough. What is being delivered? What has, instead of these promising interventions, what is the performance? So we need to think about that. So how do we have meaningful change? Well, resources is part of it. Otherwise, we perpetuate this kind of cruel competition that we've heard about, where we pit one group of patients against another, some kind of Hunger Games for who can be the most sick. It's a terrible metaphor, but some kind of, it's real. Who's the sickest to get any help whatsoever? Or saying that, giving to this group means we have to take from this group. That is a really sort of starvation mindset, isn't it? Scarcity mindset. And the scale of the problems that we have won't be addressed with this restrictive attitude. We will not solve the problems of eating disorders with a sort of anorexic mindset. We need to be so much more ambitious than this. And resources only part of the picture. We have to change the culture as well, to acknowledge the failures, to be radically honest, to not blame people who share their experiences, to reject a culture of ignorance that makes the injustice and moral injury of it all just about bearable for the poor people who are working in this environment. And it is not inevitable that people with eating disorders suffer and don't recover and die. It is a choice. And I don't mean that's the choice of the sufferers or choice of the families. All those in services at all. This is a choice that has been made with, consciously or not, by our society. And we have to make a different choice, basically. And the good thing is that the solutions are there. So we might celebrate this report, we might be like, great, fantastic, and absolutely wonderful, but none of us should be here. Are we going to be here in 5, 10, 20 years' time? We're here out of failure, really. So we need those people who are in policy making and political roles I'll try and find out what they need to do. I know what they need to do, but politely, we need them to empower services to help us. And we need that change. It will only happen when people stop ignoring the alarms, acknowledge the scale of the problem, and realize that those people in power have the solutions to hand. They can carry on choosing not to implement them, or they can realize they have the power to make a different choice and to save and to change people's lives. So thank you everybody for coming and supporting this. Let's hope we don't have to be here in future asking the same things, so we can say this is the change that we have made to the majority, rather than having to cry out for this again and again. And thank you to Hope as well.
Since the age of 14, I've had a label of atypical anorexia plastered all over my medical records. Some of you might be thinking, what does atypical mean? Well, in basic terms, it means I struggle with all the symptoms of anorexia, just that my BMI isn't less than 18.5. My mind is constantly thinking about eating or not eating, my body, how people perceive me, how I can restrict, and worrying about every element of my appearance. However, because of the word atypical, I've been continuously met by inadequate, inaccessible treatment. Throughout the time that I've had anorexia, my relationships have been affected. I've had to take time out of work, I've had to quit university, and I constantly felt like I was failing. Not only failing at life, because I wasn't able to do all the things that had been expected of an A-star student, but also failing at having an eating disorder because it was atypical. Why would we use such a word to describe something for somebody that is trying to achieve something of perfection? Atypical really does take all of your efforts that you try away from you. Now, I'd love to say that I'm the only one having this experience. However, 4 years ago, as a result of my limited treatment, I started the Full of Beans podcast in hope of creating a space where people felt seen, heard, and validated through their experience. I couldn't find support for myself, so I wanted to create a community where we could create it for other people. Fast forward 4 years, and I now know I'm not alone. I have spent countless hours on recordings with others, getting messages to my social media, and speaking to people at events about the fact that they haven't been taken seriously, told they aren't sick enough, or to come back when things get worse in order to get support. Age 14, 18, and 21, I was told I had atypical anorexia, so I would be offered group therapy. It was the best treatment that I could get, but for me, I didn't want to sit in a room full of other people to talk. I wanted to take action. Age 26, I was fortunate enough to be in a position to find a private therapist. I actually found them through my podcast, and I listened to them talk, and I thought, wow, I finally feel understood. My therapist listened, understood, and was able to offer me treatment specific to my symptoms because she had the appropriate training. Later, I was diagnosed with ADHD and autism, and things finally made sense. With my therapist, I was able to work through how neurodiversity had impacted my existence in the world and how I use my eating disorder to cope. Without her, I would have been left thinking that it was food that I needed to change, but actually it was my relationship with the world. Whenever I speak to clinicians who aren't specifically eating disorder trained, they are fearful of saying the wrong thing. In eating disorder awareness workshops, there is never a single person who doesn't know someone who has struggled with an eating disorder, and yet we still daren't talk about it. I met with comments like, but you don't look like you have an eating disorder, or you're still eating, so surely it's fine. It's not that nobody cares or they don't want to help, it's that they've not been provided with the education that they need in order to support someone through an eating disorder. And don't get me wrong, I totally get it. At the end of the day, if I'm being honest, we are a difficult patient group. You know, we are trying to face our biggest fear every day, and that can be really difficult to support somebody with. Also, probably going to get kind of angry when you ask me to face this. However, with the training, alongside other factors, this results in misdiagnosis, unrecognised symptoms that can lead someone to getting further entrenched in an eating disorder that could have been prevented. It is vital that healthcare teams begin to work together when supporting a patient. More and more, we're hearing of comorbidities such as depression, anxiety, OCD, hypermobility, chronic fatigue, neurodiversity. The list goes on. If we're not aware of how these conditions can impact each other or how they are being supported alongside each other, we are failing patients by not providing support unique to them. In my example, I needed to have emotion-focused therapy because I just didn't understand what emotions were. Through having autism, I was only thinking that there was happy, sad, and potentially sometimes angry, although it felt very hard to experience. But by having specific treatment that meant I could understand my emotions, I no longer needed to rely on everybody else's expectations of me or opinions of me, the way that my body felt, the way that my body looked, or needing to eat in a certain way or exercise in a certain way in order to be approved by society. I stand here today very, very proud to say that I am very far along my recovery journey, and I am so happy to be here. Eating disorders are 100% recoverable, but as time goes on, it gets harder for us to recover. Eating disorders restrict enough elements of our lives, and treatment shouldn't be one of those. It's time we start to listen to those suffering and end the discrimination of those with eating disorders. Anyway.
I think the really key thing off the back of today is obviously we don't want it to just be a report for report's sake. We want it to actually kind of have meaningful action and make a change moving forward. So we've got a number of things coming up over the next 6 months, kind of year or so, which if you're interested in, please do drop me an email afterwards and I can kind of loop you in on where we're at and ways that you can get involved a little bit more. But yeah, a massive thank you.